Gastric and duodenal ulcer management. Q&A. Welcome to today's podcast, where we'll explore the comprehensive management of gastric and duodenal ulcers. We'll cover everything from causes to diagnosis, medical and surgical treatment, complications, and special scenarios. Pause the video when you hear the word answer to attempt answering questions. Let's dive into our question and answer session. Basic concepts and causes. Question: what is the difference between gastric and duodenal ulcers? Answer: gastric ulcers occur in the stomach, usually along the lesser curvature, and are commonly associated with Helicobacter pylori infection, nonsteroidal anti-inflammatory drug use, or malignancy. Duodenal ulcers develop in the first part of the duodenum and are closely linked to Helicobacter pylori infection and increased stomach acid secretion. Question: what is the role of Helicobacter pylori in peptic ulcer disease? Answer: Helicobacter pylori is responsible for about 90% of duodenal ulcers and 70% of gastric ulcers. It disrupts the stomach's defenses through urease production, cytotoxins, and by provoking inflammation. Question: how do nonsteroidal anti-inflammatory drugs cause ulcers? Answer: nonsteroidal anti-inflammatory drugs inhibit cyclooxygenase 1, which leads to reduced prostaglandin E2. This results in decreased mucus and bicarbonate secretion, as well as diminished blood flow to the stomach lining. Question: what is Zollinger-Ellison syndrome? Answer: Zollinger-Ellison syndrome is characterized by a gastrin-producing tumor, usually in the pancreas or duodenum, which causes excessive acid secretion and leads to ulcers that are resistant to standard therapy or multiple ulcers. Question: what is a Cameron lesion? Answer: a Cameron lesion is a gastric ulcer located at the diaphragmatic hiatus within a hiatal hernia. It is a frequent cause of iron deficiency anemia. Clinical presentation and diagnosis. Question: what are the classic symptoms of peptic ulcer disease? Answer: duodenal ulcer pain is typically felt in the upper abdomen and improves after eating, often occurring at night. Gastric ulcer pain worsens with food and may be associated with weight loss. Question: what findings suggest ulcer complications? Answer: perforation presence is sudden, severe abdominal pain with a rigid abdomen and free air on imaging. Bleeding may cause vomiting of blood, black stools, or anemia. Obstruction results in vomiting, weight loss, and a sloshing sound in the stomach upon examination. Question: how is Helicobacter pylori diagnosed? Answer: non-invasive tests include the urea breath test, stool antigen test, and blood antibody test, though this last one is less specific. Invasive diagnosis includes rapid urease tests and histology from biopsies taken during endoscopy. Question: when is endoscopy indicated for peptic ulcer disease? Answer: endoscopy is recommended for patients over age 60 with new symptoms, those with warning features such as weight loss, vomiting, anemia, or bleeding, or if initial Helicobacter pylori treatment is unsuccessful. Question: what endoscopic features suggest malignancy in a gastric ulcer? Answer: warning features include irregular margins, raised edges, a necrotic base, and lack of healing after 12 weeks of therapy. Medical management. Question: what is the first-line therapy for Helicobacter pylori infection? Answer: the preferred treatment is a combination of a proton pump inhibitor, clarithromycin, and either amoxicillin or metronidazole for 14 days. Alternatively, bismuth-based 4-drug therapy can be used. Question: how is a nonsteroidal anti-inflammatory drug-induced ulcer managed? Answer: discontinue nonsteroidal anti-inflammatory drugs if possible. If ongoing use is necessary, prescribe a proton pump inhibitor along with a cyclooxygenase 2 selective drug. Question: what is the role of sucralfate? Answer: sucralfate forms a protective barrier over ulcers and is commonly used for stress ulcers in patients in intensive care, but it does not treat Helicobacter pylori infection. Question: how long should proton pump inhibitors be continued for ulcer healing? Answer: duodenal ulcers generally require 4 to 8 weeks of proton pump inhibitor therapy, while gastric ulcers need 8 to 12 weeks due to the risk of malignancy. Question: when is testing for Helicobacter pylori cure needed? Answer: testing is done 4 weeks after treatment is completed, using either a urea breath test or stool antigen test. Surgical management. Question: what are the indications for surgery in peptic ulcer disease? Answer: surgery is needed for ulcers that have perforated, are causing persistent bleeding, are blocking the stomach outlet, or when there is suspicion of cancer. Question: what is the surgery for a perforated ulcer? Answer: The standard procedure is a gram patch, which involves covering the perforation with a piece of omentum, and washing out the abdomen. Question: what is the surgery for a duodenal ulcer that does not heal with medication? Answer: surgical options include truncal vagotomy with opening of the pylorus, or vagotomy with removal of the stomach antrum for Zollinger-Ellison syndrome. Question: what surgery is performed for a bleeding gastric ulcer? Answer: options include removing the ulcer through wedge resection if benign or performing a partial gastrectomy if cancer is suspected. Question: what is a highly selective vagotomy? Answer: this procedure preserves nerve branches to the pylorus, eliminating the need for additional drainage operations, and is used for chronic duodenal ulcers. Complications. Question: how is ulcer bleeding managed? Answer: initial management involves endoscopy with injection of epinephrine and thermal coagulation or mechanical clipping. Intravenous proton pump inhibitors stabilize the clot, and radiological embolization or surgery is considered if bleeding persists. Question: what is the Forrest classification? Answer: this endoscopic system grades bleeding ulcers as follows: IA or IB for active spurting or oozing, requiring urgent intervention, and IIA or IIB for visible vessels or adherent clots, high risk of rebleeding. Question: how is gastric outlet obstruction managed? Answer: initial treatment is endoscopic balloon dilation, while a vagotomy with a surgical stomach bypass provides a definitive solution. Question: what is the mortality rate of a perforated ulcer? Answer: death occurs in 10 to 30% of cases, and the risk is higher if treatment is delayed more than 24 hours. Question: what causes dumping syndrome after vagotomy? Answer: rapid emptying of food into the intestine results in fluid shifts and dilation of blood vessels, causing symptoms. Diagnosis and causes. Question: what is a doulophous lesion? Answer: it is an erosion of a submucosal artery without an actual ulcer, causing massive bleeding. Treatment is endoscopic clipping or coagulation. Question: how is Zollinger-Ellison syndrome diagnosed? Answer: fasting gastrin levels above 1000 picograms per milliliter and a stomach pH below 2, with confirmation by a secretin stimulation test that shows an increase in gastrin. Question: what is the role of upper gastrointestinal endoscopy in bleeding ulcers? Answer: it is the best method for diagnosis and therapy, with the Forrest classification guiding treatment. Question: how is Helicobacter pylori treated in patients with penicillin allergy? Answer: a bismuth-based 4-drug regimen or a levofloxacin-based combination is used. Question: what is the risk of stomach cancer after Helicobacter pylori infection? Answer: there is a 1 to 3% risk. Eradication lowers but does not eliminate this risk. Ongoing endoscopic monitoring is recommended if stomach lining changes are present. Medical management. Advanced. Question: what is stress ulcer prevention in patients in intensive care? Answer: use proton pump inhibitors or histamine 2 receptor blockers for ventilated patients or those with blood clotting disorders. They are not needed for low-risk individuals. Question: what is the approach in persistent Helicobacter pylori infection? Answer: use culture-guided therapy or a 14-day bismuth-based 4-drug regimen with high-dose proton pump inhibitors. Question: when should blood gastrin be tested? Answer: after 7 days without proton pump inhibitors. Elevated gastrin may suggest Zollinger-Ellison syndrome, atrophic gastritis, or ongoing medication use. Question: how is Helicobacter pylori managed during pregnancy? Answer: avoid tetracycline and bismuth. Amoxicillin, proton pump inhibitors, and metronidazole may be used in the later stages of pregnancy. Question: what is the role of vonoprazan? Answer: vonoprazan is a potassium-competitive acid blocker, used as an alternative to proton pump inhibitors for Helicobacter pylori eradication, especially in Asia. Surgical management. Advanced. Question: what is the difference between Billroth 1 and Billroth 2 operations? Answer: Billroth 1 connects the stomach to the duodenum, which is more natural but may increase bile reflux risk. Billroth 2 connects the stomach to the jejunum, used for larger ulcers but may cause complications. Question: what about laparoscopic repair of perforation? Answer: this is as effective as open surgery for stable patients and offers faster recovery. Question: what is a marginal ulcer? Answer: it forms at the surgical connection to the small intestine due to poor blood flow, bile reflux, or persistent Helicobacter pylori infection. Management includes proton pump inhibitors and endoscopic checks for leaks. Question: what is the role of robotic surgery? Answer: Robotic methods are used for complex reconstructions but offer no clear advantage over laparoscopy for simple repairs. Question: what is the benefit of intraoperative endoscopy? Answer: it assists in identifying bleeding sites or checking surgical connections during operations. Complications: advanced. Question: how is dumping syndrome managed? Answer: for early dumping, use small frequent meals and avoid liquids with meals. For late dumping, a high protein, low carbohydrate diet, and octreotide for severe cases. Question: how is bile reflux gastritis treated? Answer: cholestyramine or ursodeoxycholic acid is used, and conversion to a Roux-en-Y bypass if symptoms persist. Question: what causes ulcer recurrence after surgery? Answer: recurrence occurs in 5 to 10% of patients after nerve-cutting surgery, more likely if Helicobacter pylori infection or nonsteroidal anti-inflammatory drug use continues. Question: how is gastric outlet obstruction managed in malignancy? Answer: endoscopic stenting provides relief, or a surgical bypass is considered if life expectancy exceeds 2 months. Question: what about perforation in the elderly? Answer: the risk of death is higher. Consider minimally invasive repair or non-surgical management for very high-risk patients. Special scenarios. Question: how is bleeding managed in patients on direct oral anticoagulants? Answer: stop the anticoagulant, reverse with specific antidotes if available, and proceed with endoscopic therapy and intravenous proton pump inhibitors. Question: what is the approach in cirrhosis with a bleeding duodenal ulcer? Answer: band ligation is used if varices are present. Avoid shunt procedures unless high pressure in the portal vein is confirmed. Question: how is peptic ulcer disease managed in kidney failure? Answer: adjust the dose of proton pump inhibitors. Sucralfate is preferred in dialysis patients. Avoid prolonged use of omeprazole. Question: what is autoimmune gastritis? Answer: this increases the risk of pernicious anemia. Monitor vitamin B12 levels and avoid acid suppression unless there is concurrent Helicobacter pylori infection. Question: how is Behçet's disease-related ulcer managed? Answer: colchicine or steroids are used for mouth and digestive ulcers, with surgery only for perforation. Oncology and advanced therapies. Question: when is endoscopic removal used for early stomach cancer? Answer: endoscopic removal is reserved for very early cancers less than 2 cm without ulceration, with follow-up endoscopic monitoring. Question: what is the use of positron emission tomography in stomach cancer? Answer: positron emission tomography has limited sensitivity for some types of stomach cancer but helps detect cancer spread. Question: what is neoadjuvant therapy in stomach cancer? Answer: the FLOT regimen, consisting of fluorouracil, leucovorin, oxaliplatin, and docetaxel, is used for locally advanced tumors. Question: what about PD-1 inhibitors? Answer: pembrolizumab is used for metastatic stomach cancer with certain biomarkers. Question: what about hyperthermic intraperitoneal chemotherapy? Answer: this treatment is considered experimental for widespread cancer in the abdomen and may be combined with surgery. Endoscopic techniques. Question: when is endoscopic stenting used for stomach outlet obstruction? Answer: metal stents are preferred for cancer-related obstruction, with a 20% migration risk in benign cases. Question: what is endoscopic vacuum therapy? Answer: this is used for surgical leaks or perforations and requires repeated endoscopic procedures. Question: is peroral endoscopic myotomy useful for obstruction? Answer: it is not standard for mechanical obstruction. Pylorus cutting may be an option in stomach paralysis. Question: what is confocal laser endomicroscopy? Answer: this is a research tool for real-time tissue examination, not yet standard practice. Question: how is artificial intelligence used in endoscopy? Answer: artificial intelligence systems such as computer-aided detection improve early stomach cancer diagnosis. Hematologic considerations. Question: how is bleeding managed when platelet count is below 50,000? Answer: transfuse platelets before endoscopy and avoid injecting epinephrine due to the risk of tissue damage. Question: how is von Willebrand disease managed? Answer: treat with desmopressin or clotting factor concentrates and avoid nonsteroidal anti-inflammatory drugs. Question: what is the management of heparin-induced thrombocytopenia with bleeding? Answer: use argatroban and avoid all heparin products during endoscopy. Question: how is bleeding managed in patients with a left ventricular assist device? Answer: keep the international normalized ratio between 1.5 and 2. and consider an octreotide drip to reduce blood flow to the stomach. Key statistics and mortality question. What is the most common cause of death in peptic ulcer disease? Answer. The leading causes are severe blood loss and infection from perforation. Question. What is the mortality rate for perforation? Answer. The death rate is 10 to 30%, higher for those over 70 years old or with delayed treatment. Question. What is the prognosis for stomach outlet obstruction due to cancer? Answer. Median survival after stenting is 3 to 6 months. Rare causes question. What is Helicobacter heilmannii? Answer. This is a rare infection acquired from animals. Management is similar to Helicobacter pylori. Question. How is mastocytosis relevant to ulcers? Answer. Mastocytosis can cause histamine-driven ulcers. Treated with antihistamines. Avoid nonsteroidal anti-inflammatory drugs. Question. What is eosinophilic gastritis? Answer. This is managed with steroids or an elimination diet. Endoscopy shows ridges on the stomach lining. Palliative care question. When is palliative removal of part of the stomach indicated? Answer. Only for non-stop bleeding or blockage that does not respond to other measures. Question. How is do not resuscitate status handled with perforation? Answer. Choose non-surgical management, such as stomach rest and antibiotics, if the focus is on comfort. Thank you for joining us for this in-depth question and answer session on gastric and duodenal ulcer management. For more medical deep dives, stay tuned to our channel.